So Fatima Kakkar is going to go through the congenital CMV infection among children exposed to HIV in utero in Montreal.
I'm feeling very tall. Well, thank you for staying so late in the day, and I hope I can convince you in this next 5 minutes why congenital CMV is something we should all be thinking about. I do have a conflict of interest in that the CMV testing kits for the study were provided in kind by the Altona company. So congenital CMV infection is actually the leading cause of non-genetic sensorineural hearing loss worldwide, and actually one of the most common causes of global developmental delay, with estimates of anywhere from 1 in 100 to 1 in 150 live births. And we know that women living with HIV may be at higher risk of CMV reactivation during pregnancy or even CMV reinfection. And this is data from the pre-ART area that shows strong correlates between their HIV viral loads and their CMV viral loads. And our speakers earlier today have done a great job showing us that children who are HIV exposed and uninfected are at increased risk of speech and language delay and neurodevelopmental delay. And so a natural question is congenital CMV contributing to this? And children who are exposed to CMV are not routinely, who are exposed to HIV are not routinely screened for congenital CMV infection. CMV screening across the world is really country and even jurisdiction dependent. So the objectives of our study were really simple: to look at the risk of congenital CMV infection among children exposed to HIV here on our Montreal cohort, and to look at risk factors for CMV from among maternal and infant characteristics. This was a retrospective study of mother-infant pairs that have been enrolled in our local Montreal cohort dating back from 1988 to the year 2020. And infants were included if we had a stored serum or plasma sample between birth and 21 days of age, or a clinical sample had been tested for CMV, which was saliva and confirmatory urine if positive. Serum and plasma samples were tested on the AltoStar automated platform with a limit of detection of 250 units per ml, and clinical samples were tested using an in-house CMV PCR with a limit of detection of 200 copies per ml. And so these are our results. So we had over 1,112 mother-infant pairs in our cohort, which is a very old historical cohort, of which we had 1,072 children who were HIV exposed uninfected, 726 had available birth samples, and 11 were confirmed retrospectively, so 1.5% to have congenital CMV. We had 40 vertical transmissions. Now again, this is the historical cohort. And unfortunately, we only had 6 available birth samples, but quite remarkably, 2 of those 6 tested positive for congenital CMV, one of whom is actually currently in our clinical care and in retrospect has global developmental delay, hearing loss, and even diagnosed with autism, which in hindsight is likely her congenital CMV. We then looked at results by year of birth, and clearly it was the older birth cohort, so really in the pre-ART or the early ART era where we had the highest incidence at 2.2% and quite low in our recent era of 0.5%. And I've also included where the majority of our missing samples came from, because again, the majority came from the pre-era prior to 1996. So just to highlight how these numbers are likely an underestimate because we are missing a lot of older birth samples. We then looked at maternal characteristics, and I was quite surprised to see these results, and that the risk was very elevated when we looked at infants born to moms who are at high risk of HIV transmission. So when there was a detectable viral load, according to the best measure available at the time, 50 or 500 copies, the incidence was 3.8% versus 1.2% among infants born to moms who were undetectable. When we looked at them by CD4 count, so when moms had a CD4 of less than 250 copies per ml, the incidence was 4% versus moms who had higher CD4 counts where it was 1.4%. Now I've added in the p-values there, and you'll note that they're not statistically significant, which I think is a reflection of our small cohort size, but I think the trends do speak for themselves and that these are babies of sicker moms, and it fits with what we've known before. We then looked at some basic infant characteristics, and this was quite striking in that when we looked at birth weight, so infants who were low birth weight, the incidence of congenital CMV was 5% versus those who were above 2,500 grams at 1%, and this was statistically significant, but there was no difference when we looked just according to gestational age. So in summary, in our cohort here in Montreal, children who were HIV exposed had a 3-fold higher risk of congenital CMV compared to general population estimates. And this risk was highest among HEU infants born to moms who were low birth weight or born to moms who had low CD4 or high viral loads at time of delivery. Now, our study does have a large number of limitations in that it's a small cohort, so we have limited statistical significance. And it's likely, however, that our overall estimate is underestimated because we're missing a lot of samples from the older era. And we've been using serum, which has a much lower sensitivity than current tests which use urine. So this 1.5 is likely a significant underestimate. And so in spite of these limitations, I think given all of our concerns about neurodevelopmental delay among children who are HIV exposed and children who are HIV infected, these data do suggest, in my opinion, that all CHU should be tested for congenital CMV at birth. And we're really fortunate here in Canada. We have a very small group of perinatal ID experts, all of whom get along. So we were able to put this into our national Canadian CMV screening guidelines so that all HIV-exposed children are screened for CMV at birth. And so I recognize, though, that this is a huge ask on systems. And where resources are limited, however, I do think we could prioritize newborns who are especially at high risk of perinatal HIV, born to moms with detectable viral loads or very poor immunological control, or even targeting infants who are very low birth weight at less than 2,500 grams. So with that, I conclude, but not without thanking our fabulous clinical cohort teams who've all contributed to the collection of these specimens over the last almost 30 years. Thank you.